Hi, I'm Tim Horton. I'm an Assistant Director at the Health Foundation. And today I'm going to talk about what we know about how to adopt innovation successfully and how we can use that to make the most of some of the key service changes we've seen during COVID. I'll start by briefly mentioning some of the Health Foundation's learning on spread and adoption. And then I want to look at some of the key service changes we've seen during COVID and the objectives behind them. Then I'm going to explore why the fact that these have been implemented during COVID poses a challenge. And finally, we'll finish by looking at what might be required to sustain and embed some of these changes for the long term. At the Health Foundation over the last few years, as well as funding teams directly to spread and take up new ideas, we've also been working with them to explore why adopting innovation can be a challenge. For many types of healthcare intervention, whether a new way of working, pathway redesign, or new technology, what we often see is there can be a big difference between putting the form of an intervention in place versus delivering the intended outcomes. And a couple of years ago, in our report, The Spread Challenge, we sought to shine a light on why effective adoption can be such hard work. A basic point is that many healthcare interventions are sensitive to their context, by which I mean the organizational systems and culture they're being implemented in. And the outcomes will emerge from the interaction of an intervention and its context. And this means two things in particular. First, you can't just drop a new innovation into a setting and expect it to work perfectly. It might need to be adapted to its context. So in a survey we did of adopters in the Health Foundation's programs, 8 out of 10 of them said that they had in some way had to adapt the innovation they were taking up in order to make it work in their setting. So the intervention has to be right for its context. But the second point is that the context also has to be right for the intervention. There are a whole set of factors, and I've put some in a slide here, a whole set of factors that might need to be present in order for the intervention to work. I'm talking about capabilities and skills, things like methods and techniques, and also cultural things like values and behaviors. So these are some of the reasons why effective adoption can be such a challenge. Now, it's really interesting to reflect on these challenges in the context of COVID, because over the last few months, the NHS has been through a remarkable period of change. We've seen in a short space of time some significant service shifts, everything from new triage processes for primary care to new outreach services for vulnerable groups. We've also seen significant developments involving technology, increased use of remote consultations, increased remote self-monitoring at home, virtual visiting, increased use of professional-to-professional telehealth to support clinical decision-making, and so on. Now, it's interesting to note that, obviously, while it's the need to respond to COVID that's been driving this stuff, actually, several of these developments, like greater use of remote self-monitoring, have actually been long-standing NHS objectives, perhaps with limited progress in the past, but where the need to respond to COVID seems really to have turbocharged the uptake and rollout of these changes. Specifically, I think where there's been a long-standing NHS objective, like demand management, that aligns with a COVID response objective, the effect has been really to accelerate reforms that were already on the agenda, like more proactive triage or increased use of patient-initiated follow-up in outpatient services, and things like that. By contrast, I suspect there will be other programs of work that have been put on hold, perhaps where there were quality improvement objectives that didn't immediately serve the needs of responding to COVID. But nevertheless, it's interesting to note that while COVID has obviously been driving things over recent months, it's nevertheless accelerated the implementation of some quite long-standing NHS priorities. Now, the speed at which some of these service changes have been rolled out has been impressive. And in some quarters, that's led to talk of locking in, a sense that COVID's really helped shortcut the rollout of some major service changes. And with the job now done, we can lock them in for the future. To me, talk of locking in seems premature for a few reasons. First, there's been limited evaluation of some of the changes we've seen in recent months. So to take an example, the Q community during COVID have been working with teams implementing video consultations. And what their work has surfaced is, on the one hand, pride about the progress that's been made in putting video consultations in place, But on the other hand, it's also surfaced some concerns about accessibility and digital exclusion for certain groups of patients. So in cases like this, we're clearly going to need more evaluation and interrogation of what the impact has been. It's also the case that many of these changes have happened without much patient consultation, which is totally understandable in a public health emergency, but it's something that's going to need rectifying before committing to these changes for the long term. Another, perhaps more subtle reason for caution is that even where the case for a service change is well made, if we look over the long term, it's clear there are going to be shifting objectives behind some of these innovations. So let's stick with remote consultations as an example. If we go back before COVID, the interest in remote consultations was to improve patient experience and access, improve clinical productivity, and maybe also free up some NHS estate, all important objectives. During COVID, by contrast, remote consultations have been expanded primarily to achieve social distancing, and they automatically do that. But just because teams have implemented remote consultations to achieve social distancing doesn't mean they've yet achieved or even come close to achieving those wider quality and productivity objectives we're going to want remote consultations to serve over the long term. So it's important to remember that while COVID has accelerated the rollout of some healthcare interventions, in future, these interventions might need to be reoriented in order to serve a wider set of objectives. So what's going to be required to embed and sustain the innovations we've seen during COVID? Well, first, in light of what we've just been discussing, there might be a need for teams to revisit aspects of implementation that have been shortcut by COVID. So that means evaluation of these changes to make sure they're safe and work for all groups of patients. It means more patient consultation and co-design, and staff consultation and co-design too. Indeed, there might be a need for some of these changes to actually develop and secure consensus about their ongoing use beyond COVID. And there might be other implementation needs as well to address, like training needs, infrastructure needs, and so on. Second, there'll be a need to reorient some of these innovations towards serving longer-term quality and productivity objectives. So, for example, how do we make remote consultations again be about that improved patient experience and access and improved clinical productivity? How do we make the increased use of apps and devices for monitoring health at home develop from just a good way of monitoring health during a time of social distancing into a way of truly empowering patients to manage their own health at home? These kinds of changes are going to require evolution of the service approaches in question. Third, there'll of course be a need to refine the use of these innovations. To do that work we were talking about at the beginning of adapting innovations to their context and continuously improving them in order to maximize their benefits. A question I'm sometimes asked is, doesn't the fact that stuff's been rolled out quickly during COVID really show that adoption can be quite simple? And in fact, when the will's there, we can get stuff done quickly. To which my short answer is no, not necessarily. And it goes right back to the distinction we made at the beginning between putting the form of an intervention in place versus delivering improved outcomes as a result. Just because teams have implemented things rapidly during COVID doesn't mean that further work isn't going to be required in order to adapt these innovations to their context and to iterate and customize them in order to ensure we're getting the most out of them for the long term. Let me finish by saying, if you're interested in this topic, then please do look at our report, The Spread Challenge. You'll also want to keep an eye on our new program, Adopting Innovation, which is going to support providers and local health systems create the conditions for effective adoption. And also look out for the next round of the Q Exchange program, which is going to support teams to embed some of the positive service changes we've seen during COVID. Thank you for listening.